I'm Professor Isabel Deisenhofer. I'm the head of the Department of Electrophysiology at the German Heart Center Munich, which is a clinic of the Technical University of Munich. And I've been working there for a long time, heading now the department and being there with the Technical University for about 20 years now. Yeah, the background is that we have problems in reaching higher success rates in eliminating persistent atrial fibrillation. So we are quite good at eliminating paroxysms of atrial fibrillations, but as soon as the atrial fibrillation turns to be persistent, we have problems with our ablation strategy. And so far, in the landmark trial STAR-AF2 in 2014, it has been proven that no PVI plus, so no additional ablation to just a standard of care pulmonary vein isolation was really significantly helpful in helping these patients. And in the meantime, since 2014, we've been striving to find some other technique, technology, strategy to have a PVI plus strategy that really benefits patients. And we weren't successful until this trial, more or less. It's a system that takes intracardially recorded electrograms, and it takes them from high-density multipolar catheters, and then analyzes these electrograms, the single electrograms, but more importantly, the relationship between these electrograms. So it's all more or less analyzes the conduction properties of a small distinct area during ongoing atrial fibrillation. And then these recordings are compared, and that is using artificial intelligence to a data set of electrograms that have been stored and adjudicated and annotated by expert electrophysiologists. So in short, we compare the current electrograms of this patient with previously recorded and then the electrograms are adjudicated as important, and that means that we can see there a spatio-temporal dispersion, so a very interesting and probably defining conduction property during atrial fibrillation, or there is no dispersion. And then these areas that exhibit these dispersed electrograms, you can then tag them on your 3D map in the ongoing procedure. And all of this is a very swift workflow. So it's online analysis. You send the EGMs to the machine. You don't even send it by yourself. It's just done automatically. The things are analyzed, and then within a few seconds you get the output of the AF-Xplorer. Oh, there's dispersion there. No, there's no dispersion there. Yeah, so we included a little bit longer lasting atrial fibrillation patients, so from a duration of 3 months up to 5 years in the US for regulatory for 1 year, persistent AFib patients. And we then randomized them to a standard of care pulmonary vein isolation alone, so the standard of care thing that we all do, versus a tailored ablation approach where we go after these dispersed areas after detecting them in a biatrial map, and then also add up pulmonary vein isolation. So the one is really PVI alone, and the other one is, if you want so, PVI plus this EGM-driven AI-supported target areas that we ablate additionally. Exactly, and we included about 370 patients in about 26 centers. So a large study. It's a multinational study with 5 participating countries. And we had 51 operators who performed the ablation procedures just to prove that this can be done by anybody, that you do not need any previous experience with the system. In short, the results were looking for a primary endpoint, and the primary endpoint was freedom from any atrial fibrillation on or off drugs after 12 months in a single ablation procedure. Secondary endpoints comprised the same settings, so freedom, but this time freedom from any atrial arrhythmia after 12 months and an on and off draft, and after a single procedure, and then also this freedom from any atrial arrhythmia after up to 2 procedures, because what was allowed in the study protocol was a redo ablation after month 6, you could include a second ablation. The second ablation had to be a PVI plus a maximum of 2 lines in the anatomic arm again, and in the tailored arm, we perform just the same tailored ablation procedure again. And what I forgot to say, and that's very, very important in the study, and we really took a lot of care on that, we had a very stringent 12-month ECG follow-up to be really sure that these patients had no recurrence. They underwent several Holter ECGs, and they had to send in weekly cardia, so transmission, ECG transmission on a weekly base, and in case of symptoms. So in the end, we had 17,000 ECG recordings that were analyzed, and these were analyzed by a blinded and independent core lab. So the ECG analysis was not done within the group of centers, but in an independent core lab. Regarding the outcome, the primary outcome, we found a very striking and extremely positive benefit for the patients that were ablated additionally. So in the tailored group, we had about 88% of patients who were free of AF in that for the month of 1 year, whereas in the anatomic arm, we were at 17%. So there was really a striking difference of 18% between these two groups. We predefined also 2 subgroups in the study to be sure that we could also have a look at who is especially benefiting from that tailored approach. And in this pre-specified subgroup of the patients with longer-lasting AFib or with an AFib that was present at the beginning of the procedure, so higher burden atrial fibrillation patients, we could show that even the secondary endpoint, so freedom from any atrial arrhythmia after 1 or 2 procedures, was significantly better. And it has to be said that this was at the low cost of redo procedures. So we had about 25% of patients who underwent a redo procedure to get these very favorable overall results. I think the take-home message is in persistent atrial fibrillation, especially in longer-lasting persistent atrial fibrillation, after this study, I think you should think about adding already during the index procedure and tailored ablation, so an ablation of patio-temporal dispersion to your routine PVI. So not stay with the PVI alone, because the freedom from atrial fibrillation is significantly higher than in these patients. And regarding then the outcome, which is so important for the patient himself, so what about the freedom from any atrial arrhythmia? You fare also better using this approach, because when you do this tailored approach already for the first procedure, patients will come back with not with atrial fibrillation predominantly, but the recurrence arrhythmia is an atrial tachycardia, which is much easier to ablate. It's an understandable arrhythmia, and it's something that we can successfully ablate. So the overall freedom of any arrhythmia was reached in our study in a lot of patients after 1.2 procedures. So adding 1 more procedure after an initial tailored approach was sufficient. So in summary, you should do more than PVI during the index ablation, and then you prepare the success for a possible repeat ablation. I think the next steps are now really to look into we have a bunch of data. It's 370 patients followed up over very closely over 1 year. We have so many interesting subgroups. We have where did we perform the dispersion areas, where we define them. Analyzing all this will, I think, generate such a lot of hypotheses that we can all go on and on and explore really to full extent this ablation approach of AI-driven GMO dilated ablation.